Early attempts at stoma bags, as you can see in the pictures, were quite cumbersome and clunky. They were prone to leaks, and that would then lead to many problems with peristomal skin breaking down. Then Brian Brook came along, and he wrote a very famous article that was published back in 1952 on how to make the perfect ileostomy. Of note, he's also the founder of the Ileostomy Association. So this was his ileostomy. So instead of it being flush to the skin, it's now everted. So you've deliberately raised it up so it sits proud of the skin. That allows for a much better seal with the stoma bags, and it keeps all the bowel content away from the skin. Small bowel content, for those of you who have had an ileostomy and have had problems with bag leakages, is quite irritant to the skin, and it will very quickly start to break the skin down. As we move through technological advances, there's then a desire to try and avoid patients having stomas. We get better in terms of aseptic techniques. Antibiotics come along. Operating theatres change from something where it is more of a spectacle and a true theatre, where everyone who's interested in surgery will be gathered around an operating table in what are hardly sterile conditions, to something a little bit more modern. Yeah, I'd love to have an operating theatre quite that high tech. I have to make do what I have got, but things have come a long way. Aseptic techniques started back in the 19th century, and the initial basics were just washing your hands, something that previously people weren't even doing. You'd operate on one patient, then operate on the next, and the next, and the next, and you wouldn't think of washing your hands in between. They then started to use something called carbolic acid as an antiseptic, as a way of sterilizing the skin areas and instruments. Again, instruments back then would be used on multiple patients without thoughts of washing in between. Antibiotics came along in 1928 when Fleming discovered penicillin. We've now got a huge range of antibiotics, but one of the big problems is the emergence of antibiotic resistance. So as we introduce more antibiotics, the bacteria learn to adapt to become resistant to those antibiotics, and that can lead to major problems. So who is this talk actually aimed at? So most people who are going to go on to think about pouch surgery will have ulcerative colitis. That's the number one reason. But it's all about thinking of quality of life as well. So what are your options? You can stay as you are. So some people will try and keep going with the medical management of their colitis, or if they've had a subtotal colectomy, they may want to keep their ileostomy. We can rejoin an ileostomy onto the top of the rectum and do an ileorectal anastomosis. You could remove the rectum and keep your ileostomy, or you can remove the rectum and have an ileoanal pouch. But is it too late if you've already had your rectum taken out? Not really. A cock pouch may be suitable, and we'll come on to who that's suitable for a bit later on. So Alan Parks and John Nichols are a couple of very famous surgeons from St Mark's Hospital in London. And these are the guys who are really credited with pouch surgery as we know it today. Alan Parks, unfortunately, has passed away. John's now retired, but still keeps himself active academically. And there's an evolution of pouch surgery. So that we took something called an ileoanal anastomosis and cock pouch, which had been devised a few years earlier in the 1960s. They combined the thoughts of the two to create an ileoanal pouch. And at that time, it was what was known as an S pouch. So an ileoanal anastomosis is quite simply taking the small bowel and joining it onto the anal canal. It's a nice operation to do. It's straightforward. You've only got one joint to worry about. But the function that you get from it can be quite troublesome. You haven't got a reservoir. So for those of us who've got an intact colon, the rectum acts as a reservoir of stool. If you take the small bowel, which is smaller caliber, and just plumb it straight onto the anus, you're going to be going to the toilet 10 to 15 times a day because you haven't got that reservoir effect. The cock pouch was originally designed to be a bladder replacement rather than anything to do with the bowels. But it created this concept of a reservoir. If you then take that reservoir concept and join it onto the anal canal, you've now got an ilioanal pouch. And this is basically what Parkes and Nichols did back in the 70s. So they've been around a long time. So who's suitable for pouch surgery? So patients with ulcerative colitis, polyposis syndromes such as FAP or HMPCC, but there are also other selected patients, and we'll hear a bit more about Tim's journey later on, because he's come through a slightly different journey to which most people do for pouch surgery. But who's not suitable? If you've got Crohn's disease, it's considered an absolute no. Crohn's can affect any part of the GI tract, from the mouth all the way down to the anus. While some patients have their Crohn's completely isolated to the large bowel, in time to come, it can go on and affect the small bowel. And if that happens and you've got a pouch, it will only end in disaster, because you'll get all the problems of Crohn's down in the pelvis in an area that's already been operated on. If you've got indeterminate colitis, that carries a risk, because we're basically saying we don't know if you've got ulcerative colitis or Crohn's. Only about 5% of patients, after careful reassessment of the histology, will fall into that group. But when you're in an unknown entity, there's a 50% chance you could have Crohn's, there's a 50% chance you could have ulcerative colitis. We just don't know. And if you happen to drift into the Crohn's group, you're going to end up with the complications that we see in patients with Crohn's. Functional bowel disorders can be problematic for pouch surgery, because functional disorders of the bowel can affect the small bowel as well as the large bowel. And if you have a pouch, then you will likely develop functional problems associated with that. If you've got cancer in the lower part of the rectum, then it's recommended that you don't have pouch surgery, because in order to make sure we get the cancer out completely, we would normally be looking at removing the anus as well. So you then don't have anything to join a pouch onto. If you've already got problems with continence, you shouldn't have a pouch. Formed stool is easier to hold on to than something that's got a porridge-like consistency that comes out of a pouch. So your incontinence will only get worse with a pouch. As patients get older, they generally have more additional medical problems. Muscles generally get weaker, so particularly for women if they've had children, the continence side of things can be a risk. So in older patients, we tend to be a lot more cautious about who we offer pouches to. There's a bit more involved preoperative assessment to make sure we're doing the right thing, but it can still be done. And patients who've had pouch surgery in their 70s and even their 80s. Obesity can also be a risk, particularly in men. Women tend to carry their excess weight on the outside of the abdomen. Men tend to carry the excess weight inside their abdomens. One of the problems with men in particular is a lot of that excess weight sits on all the layers that support the small bowel. And if that's quite thick and chunky, it hasn't got the same mobility, so it makes it more difficult to try and get a pouch down onto the anus. So there's a higher chance of an intraoperative failure. In other words, we've set out to do a pouch, but we just cannot get it to reach down and join things back up. So do you need to have a pouch? Well, the simple answer here is no. It's a quality of life operation. You're doing this simply because you think your quality of life with a pouch will be better than your quality of life with a stoma. That's the only reason to do this. And as a result, you need to come into this surgery eyes wide open. So if I'm seeing somebody and talking to them about pouch surgery, I will give them a reading list of various places to go to, find out the information, come back and see me, go through your questions, make sure it's the right thing. Most patients, I would give them 3 to 6 months to go away, do their reading, recommend they try and come along to a meeting like this. But sometimes if somebody's got a cancer diagnosis where we need to be operating much quickly, then we may only give them a couple of weeks to do their homework. So it makes it a slightly more rushed process, but they still need to do that reading and come to their own decision that this is what they want. So we often talk about stages with pouch surgery. So there's a 3-stage, 2-stage, or even a 1-stage approach, but the 2 and the 3-stage are the most commonly used. So the 3-stage is when you have a subtotal colectomy and ileostomy to start with, and that's often done either as an emergency or at a time when you're taking lots of medication to try and control your colitis. You may be on higher dose of steroids, biological drugs. These are all things that can increase the risk of complications from pouch surgery. So it's not advisable to do a pouch at that time. You then go on to have the rectum removed, have the pouch with a covering loop ileostomy. You then subsequently have the loop ileostomy closed. 2-stage always gets a little bit tricky. There's 2 versions of a 2-stage. So there's what we call the traditional approach, which is where you remove all of the colon and rectum, make a pouch and have a covering loop ileostomy, and then go back and have the loop ileostomy closed. And then there's the modified approach, which is what's come about in more recent years, where you've already had your subtotal colectomy and ileostomy. You then have the rectum removed and have a pouch made without the need for a covering ileostomy. And then finally, 1-stage, fairly self-explanatory. You get the whole lot done in one go. So you have all of your colon and rectum taken out, pouch made, and no covering ileostomy. So when we do a subtotal colectomy, we can often do this as a keyhole operation, and it gets rid of the bulk of your disease. It allows you to stop having systemic treatment, such as high-dose steroids or biological drugs, but it also gives you that opportunity to experience life with a stoma. It's very difficult when speaking to somebody about life with a stoma or pouches when they've never experienced life with a stoma. How can you make a decision as to what your quality of life with the stoma is like? For a lot of people, the thought of having a stoma is enough to say, I'll go down the pouch route, thanks. And I've had patients before where I've done surgery to remove a bowel, do a pouch with a covering stoma, and then they've enjoyed their quality of life with the stoma so much, they've kept their stoma, and they've not had the pouch put back into continuity. They're always very apologetic about it, but it does sometimes happen. When we do a proctectomy, that's about removing the remaining disease that's left. And again, we can do this either as a laparoscopic approach. Sometimes we can do it as a transanal approach, particularly if somebody's not wanting a pouch at the same time, or it can be done as an open approach, either through a midline incision or sometimes a transverse incision just above the pubic bone, similar to what women have for a cesarean section. And we can then create the pouch at that time. When we make a pouch, we take the last 30 to 40 centimeters of the small bowel, and the most common way it's made is a J pouch because it's easy to make. So here's a bit of bowel that we folded around onto itself to make the J, and we measure up the length to make sure we're doing it correctly. Make a little opening at the apex of the J, and then we have surgical staplers that we can pass up inside. And what these do is fire a couple of rows of staples and then cut between the staples. So the pouch opens up internally as well. You normally need a couple of firings to go down the whole length, but you end up with the pouch made, and at the bottom, that sort of little blue bit is a different type of stapler. So we have a circular stapler. So you have an anvil, which is going to mold the staples, which is what that bit is. And then we pass the actual stapler gun up through the anal canal, and then the two ends can get connected, pulled down together. We can then make the join. So as you can see in that schematic, that's the anvil being connected onto the stapler. It then gets pulled down, you fire the staples, and that's the pouch anal anastomosis made. The S pouch, which was the original version of pouch surgery, is 3 limbs. It's very rarely done. It takes a bit more time to do because you've got to hand sew the construction. You can't use staplers. It can be associated with difficulties going to the toilet, particularly if that little bit at the bottom where it says 2 centimeters, if that's made too long, then the pouch can flop over on itself and kink, and that can lead to difficulties evacuating. We still occasionally use this. So if we've got somebody where a J pouch is struggling to reach down to the anus, if we flip and do an S pouch, it can actually give us an extra couple of centimeters of reach. So if a pouch is almost there, but it's just going to be under too much tension to do safely, we can do an S pouch. And I've had to do that a couple of times. The W pouch was Professor Nichols' baby. This came about in the mid-80s, and it gives a much more spherical construction. So it allows for a bigger volume. Functionally, it is slightly better compared to a J pouch. But again, it's a hand-sewn construction. It's a bit more complicated to make, and it's very rarely performed. There's still a few surgeons who use this, but for ease, most people would do a J pouch. So I'll just talk a little bit about iliarectal anastomosis. So this is where we take the small bowel and just join it straight back onto the rectum. So this is suitable for people who've had what we call rectal sparing. So for most patients who've had ulcerative colitis, the disease starts in the rectum and gradually spreads up through the bowel. But about 10% of patients will have sparing of the rectum. So the disease actually starts in the sigmoid colon, which is the bit of colon just above the rectum. So if that's been the case and it's been like that all along, there are very good candidates for having an iliarectal anastomosis instead of a pouch. For patients who've had their subtotal colectomy, we can start them on salazine enemas to see whether the rectum will respond. And if it responds to treatment and all of the inflammation settles, and when we do a camera test, the rectum distends up easily, in other words, it's compliant, then doing a join and doing the iliarectal anastomosis can be an option for those patients as well. So when we do the operation, simply take down the ileostomy, find the top of the rectal stump and tidy that up a little bit, and then join the small bowel onto the rectum, do a air leak test, so a bit like a bicycle tire test. And once we're happy that it all looks good, we can close everything up again. For most patients that have this, they will open their bowels between 3 and 5 times a day. They generally get good control of their bowels, and there's a relatively low complication rate. If they go on to get inflammation in the rectum, then they can be converted into either an ileostomy or an ilioanal pouch. So we can still go back in and take the rectum out at a later stage if we need to. So I'm going to talk a bit now about continent ileostomy. So again, this is a reservoir made from the small bowel, but we deliberately create a valve mechanism within it, and that's what makes it continent. So we're almost telescoping a bit of the small bowel. So if you imagine a telescope pulled out, you concertina it back in, one bit rolls inside the other. And that's what we're doing with the small bowel to make it continent. Because it's continent, in order to empty the reservoir, you need to pass a catheter in through a stoma, and that allows it to drain out. But you can do that at a time of your choosing. So you've got control over your ileostomy. So Neil Koch was the surgeon who developed this. So he was born in Finland and studied medicine and surgery over there. But he then moved to Sweden, and he often gets quite wrongly associated as being Swedish. But he worked in Gothenburg and had a very prolific career. So 300 publications. But in the 1960s, he became interested in developing a continent bladder. So he started this journey not as something for a continent stoma, but he was trying to come up with a way for people that need to have their bladders removed to create a reservoir that would allow them to function normally without the need for having to have a urostomy. So he did his experimental work on cats and dogs, and then in the late 60s, the first continent ileostomy was performed on a human. So his original reservoir was quite simply just a reservoir. It didn't have a valve mechanism. He thought that by having the stoma coming through the abdominal wall, that the muscles of the abdominal wall would be sufficient to keep it continent. And whilst that's true to an extent, unfortunately it's not enough, and patients were soon developing continence problems. So he then modified his design to include the valve mechanism, and that's what keeps it continent, and it's what's known as an intersusception. It's basically a long, difficult to say medical word that basically just means we've telescoped it. There's then been a few variations on the technique. People have tried using mesh to reinforce the valve. One of the problems with putting meshes around bowel is the mesh can eventually erode through the bowel, and that then causes all sorts of complications. There's also something called the Barnett's continent ileostomy, where in addition to the valve mechanism, you take a bit of the valve and wrap it around the neck of the valve that's going to come out as the stoma. So the idea being it's like a double valve mechanism. So you've got the intersusception, then as the reservoir fills up, the valve that's wrapped around the neck will also fill and apply an additional squeeze. When the ileoanal pouches came along, this actually disrupted the surgery for cock pouches. So cock pouches only really had a fairly short period of time of becoming popular before something better came along. The idea of connecting something down to the anus and allowing people to go in the normal fashion is better than passing a tube in through a stoma. It had a lower complication rate, and cock pouch surgery starts to fall by the wayside. So I was going to talk you through some of the steps of what we do with cock pouch surgery. So this is the valve mechanism. So it's basically a bit of valve that's been turned inside out on itself. We then staple it to hold it in place. So we use 3 rows of staples, and that will hold it all together. And this is my favorite part of the operation, is when we actually do the testing. So we put a catheter in, fill the pouch up with some saline, and this allows us to check all of those sutured joins that we've just made to make sure there's no saline leaking out. And if there are any little spots of leaks, we can put some additional stitches to close it up again. But we can then take that catheter out to now check that that pouch is remaining continent. So it's staying filled up with saline. So it's a nice way of just testing what you've done before you then put it all into place and close the patient back up again. So who's suitable for this surgery? So if you've already had all of your colon and rectum taken out, then you're potentially suitable. So patients with ulcerative colitis, polyposis syndromes, people who've had previous operations for cancer. But also, if you've already got an ileoanal pouch, we can sometimes convert that into a cock pouch. And you can actually use the reservoir that you've already got and flip it around to make a cock pouch from that reservoir. Who's not suitable? As with ileoanal pouches, if you've got Crohn's disease, weight is a big issue for patients with cock pouches. You need to be slim. You've got to have a body mass index of less than 30. And that's because when we make the pouch, we've got a very limited length from the reservoir to the bowel that comes out as the stoma. And that's only about 5 or 6 centimeters. So unfortunately, anyone who's overweight isn't suitable for this sort of surgery. Patients with body dysmorphia are generally encouraged not to go down this route. And then poorly controlled diabetes is a risk factor for any complicated surgery. Functional bowel disorders, as I spoke about earlier, but also if they've got lots of other medical problems, then we shouldn't be doing this sort of surgery because it's long, complicated surgery. So coming on to a bit about postoperative care. So when you come in for elective surgery, you're often quite well at the time that you're coming in. There's a much higher probability that your surgery can be undertaken as a keyhole procedure. Your length of stay is usually shorter, complications are generally lower, and you have a much faster return to normal function. For those of you who've been through emergency subtotal colectomies, you're often unwell at the time of that operation. There's a much higher chance that your surgery will be converted to open. You may need additional nutritional support, high dependency or intensive care if you're particularly unwell. Length of stay is generally longer, and there's a much higher risk of complications in the emergency setting. And you get a more prolonged recovery after your discharge. You were unwell before you started, we've then put you through major surgery. It takes a long time to recover from that. After a subtotal colectomy, you come round, there'll be tubes everywhere. You've got an ileostomy, which you've now got to get used to, in addition to trying to recover from your major bowel surgery. But with elective, it's much easier. We can build up your oil intake a bit quicker. You can then have your progressive removal of your tubes, as well as your stoma training. You start to get used to life with the stoma. get some physiotherapy to help with breathing, getting you mobile, trying to get you home. A lot of patients these days are sent home with Lexane, that's a blood thinning injection to try and minimize the risk of blood clots post-operatively. After your pouch surgery, we then get you back for a contrast enema, which is where we put a dye that shows on x-rays up inside the pouch just to make sure there's no signs of any leaks. We then normally see you about 6 weeks after your surgery, and if all's well, we can then get you booked in for your stoma reversal. Ideally, that's within 3 months of your pouch surgery. After the pandemic, waiting times were going up quite a bit. Things are generally coming back down. I think most centres now are looking at about 3 months for reversal of stoma after a pouch. Postoperative care for ileorectal anastomosis is very similar to when you have your colectomy. We normally leave a tube inside the bottom end just to take the pressure off the joint, and that's typically left for 5 days. But if the bowels get moving a bit more quickly, then we normally get that out sooner, and typically home around about day 5 to day 7. Cock pouch is a very different beast. It's only done as an open operation. There's no keyhole version, so everybody gets an epidural. There'll be drains in place, there'll be a catheter into the bladder, but also a catheter that's left sitting inside the stoma. You start off on clear fluids only, and that includes high protein juices. The catheter in through the stoma is going to stay for some time, and it's on continuous drainage. The epidural comes out on day 3. Bladder catheter normally comes out the same day or the following day. But we don't start introducing a soft diet until 10 to 12 days after the surgery. And this is because we're trying to give the pouch time to heal. We don't want to put too much through that whilst all those suture joins are healing. The catheter that's sitting in the pouch is the only thing that's protecting it whilst it's healing. But as you get nearer to going home, we then start teaching you how to spigot that catheter off, as putting a bung on the end. Typically, you go home about 2 weeks after surgery. You'll then do intermittent spigoting. So you will leave the catheter in the pouch, but you'll cap it off, initially for a couple of hours at a time, then gradually building it up over the next 2 weeks. And the idea is that that gradually allows the pouch to start stretching up a bit more, getting distended, but each night you connect a drainage bag onto the tube. So overnight, you can get a good night's sleep. You don't need to worry about having to take the bung out. And then during the day, you go back to the intermittent spigoting. When we see you on the ward after about 2 weeks, and the stoma nurse himself would then take the catheter out, give you a new catheter, and show you how to pass the catheter into the cock pouch. And then, having had a few practice goes, you're good to go. And then head home with your fully functional cock pouch. Complications occur with any operation that we do. So with all major abdominal surgery, there's a risk of infection, bleeding, blood clots in the veins in the legs, small risk of injury to the ureters. So these are the tubes that come from the kidneys down to the bladder. But there's also a risk of injury to other structures. With the ileorectal anastomosis, there's a risk of the join that we make between the small bowel and the rectum not healing properly, and we have what's called a leak. You can get recurrent inflammation within the rectum. In the longer term, you can develop malignant change, and this is something that can happen to anybody with long-standing colitis. And these are the reasons where you may then need to go on and have the rectum taken out. With ileoanal pouches, again, there's that risk of leaks from the join, but the joins can also narrow down or stricture. So risk of infection in the pelvis if you do get a leak, risk of injury to the nerves that run around where the rectum was. And these can lead to problems with erectile function, ejaculation, or sexual function in women, as well as bladder problems. In women, there's a risk of reducing fertility or fecundity. So this is your ability to conceive and carry a pregnancy. And that's a risk with any pelvic surgery. So for young women going through this type of surgery, it's important that we talk to them about their options, make them aware of what the risks are, and some patients may prefer to defer having pelvic surgery until after they've completed their family. There's a small risk of fistulas developing. Sometimes the pouches can have a poor functional outcome, so even when it's technically been absolutely perfect, they just misbehave for reasons that we can't quite work out, and you end up with patients struggling with going to the toilet far too often. And ultimately, pouches can fail, and the risk of failure is about 0.5 to 1% each year. With the cock pouch, again, there's the risk of leaks from the join, small risk of fistulas. The valve mechanism can unravel and desuscept. In other words, you've now got a continent ileostomy that's incontinent. The reservoir where it's anchored up onto the abdominal wall can sometimes detach, and the reservoir sinks backwards, and that can lead to difficulties with intubating the pouch. Because of the trauma of repeated intubations, the stoma can shrink down, and ultimately you can end up losing the pouch. So what are the pros and cons of all these different approaches? So with an ileorectal anastomosis, you've got the improved body image of not having a stoma. You don't need stoma bags, and it avoids pelvic surgery. But there's a risk of the colitis flaring in the rectum, as well as a risk of cancer in the rectum, and you may end up needing further surgery to remove the rectum in the long term. With an ileoanal pouch, again, there's that improved body image of not having a stoma. You've got a normal passage of stool through the anus, but there is a risk to your fertility and fecundity. The functional outcome can be variable, and there is an associated failure rate. With the cock pouch, again, there's an improvement in body image. You don't have a stoma that's spouted. It's usually a bit more discreet and lower down compared to a conventional ileostomy. You don't need to have stoma bags, and you've got control over your stoma activity. However, it's a more complicated operation. There's a much higher complication rate, and up to about 50% of patients will require further surgery if they've got a cock pouch. But there's also very few consultants performing this. As we spoke about earlier, I'm currently the last man standing. I know there's other consultants who are interested, particularly down in Oxford, and up in Scotland. Currently, we've got nobody doing this. And because of some of the restrictions around how patients can move within the NHS, if you're in Scotland or Wales, you can't come and see me. They don't allow transfer of care across the borders. Whereas if you're in England, you've got patient choice. You can choose your consultant within a 200-mile radius of where you live on a GP referral, or you can be referred nationally if it's a tertiary referral from a consultant. Thank you.